Hey everyone, welcome to Hump Day Happy Hour, hosted by Dentists in the Know. This is the webcast where dentistry meets real talk, real news, and just the right amount of sarcasm. We are pulling back the curtain on the industry. We're talking to the experts, the innovators, the everyday clinicians who are out there doing the work. There's no fluff, no filter, and definitely no sales pitches disguised as education. Do I sound like I'm selling a used car?
A little.
I feel like it sounds like I'm selling a used car. I'm going to do this better, though. If it's happening in dentistry, from clinical insights to regulatory curveballs to the latest scandal at the ADA, we are probably already talking about it. And yes, we are bringing the goods. So whether you're a seasoned doc, part of a dental team or industry, a curious consumer, or maybe you're just here for the banter, we welcome you all to the show, because around here, we are not just in the loop. We are in the know. Hey there, everyone. I'm Dr. Jeff Horowitz, accompanied by one amazing clinician and friend tonight, not dos, uno, and that is Dr. Jennifer Bell. The three of us, Dr. Chad Duplantis, Dr. Jennifer Bell, and myself, we created this platform to make the dental world just a little bit smaller, but a whole lot more fun. Today, we have a great topic. We have a wonderful guest tonight. We are joined by some of the faculty from Full Arch Masters. They're going to help teach us about selling large cases and how to provide full arch implant therapy. We'll talk about that tonight. We are proud to be presenting once again on a Wednesday night, and I am proud to be sitting by you, JB, or at least across the screen from you. How you doing?
I'm great. Do you think that hold on, I'm checking. I'm gonna have to resend some stuff. Okay, I have a question I need you to ponder on.
Okay. I'm pondering. I'm in ponder mode.
Okay. Do you think that when patients say my right, what do they mean?
Well, for some of them, they will say my right and point to the opposite side because it's what they see in the mirror.
Correct.
Yes.
But also, why do they have to caveat that? Like, they'll point to something, they'll say, "Oh, but I mean my right." And I'm like, "No, we have the same rights. My right side is the same."
It looks like they're left in the mirror. So I think they're just confusing themselves.
I think so. But I'm like, yeah, no, I know it's my right too.
Yeah.
You know.
Yeah. Well, we think of the same right side, you know. It's just you may have a different perception because of what you see in the mirror.
Right.
So yeah. No, I mean, all the time, you know, people say my right side really hurts and they'll do this. And I'm like, well, that's not your right side. Well, they're like, well, it is when I look in the mirror. I'm like, yeah. But that's not.
But the same is true. Like if I say you have something going on here.
Yeah.
And I'm actually pointing to the same side that I'm referring to the same side, but they're like, oh, you mean over here? And I'm like, no, still like samesies. We're both the same.
But what about this? So what if you look like them and then they think, well, this is just like the mirror.
Right.
I know. Problem.
Clearly.
You just setting up all kinds of issues here. So
maybe that's the value of an intraoral scan. Just take it away from yourself altogether.
Take the whole mirror thing out of the equation.
Yeah, just do the scan.
I like it. Yeah.
Just do the scan and you'll be fine.
You have just made an excellent argument for doing an intraoral scan on every new patient.
Because it doesn't go well when you're like, no, I mean, like my right is the same as your right. Yeah. Still just talking about right. It's all the same right or the same left.
And the worst thing was when you would like hold up x-rays, you know, then it's like,
forget it.
Yeah.
I can't even imagine that world where you had a tiny film and you're just holding it up going, yeah, can you see what I see? You got it?
But you tell me the truth. You had to live in that world a little bit.
No, I did. Okay. Before we get in the news, I'll tell you.
You're not that young, JB.
I'm young enough, my boo. Young enough. Now, I'll tell you my first experience with film. I was an intern.
What would do? Is this PG?
It's PG.
Okay.
It's a horrific story. It's a
It
horrific
all
story of
started on
horrific
the casting
proportion.
couch.
Yeah, right. So the reason I got into dentistry in the first place was my hometown dentist who I came home to see that summer, or like in the spring break, maybe. He was genuinely curious about what I was going to do. And I said, oh, I think I'm going to go to med school. And he said, oh, you don't want to do that. And I said, no, I think I do want to go to med school. He goes, no. You want to go to dental school. And I was like, that seems kind of dorky. He's like, I tell you what, just come work for me for the summer. I was like, really? You're offering me a job? And it paid more than lifeguarding. So I was like, yep, that sounds like a great idea. $2 an hour more in. All right. So I get there and now they're crash coursing this poor college girl who knows nothing about nothing. Okay. So this one dental assistant took a full mouth series and I had developed a couple x-rays. I had to go into the dark room by myself. They'd walk me through the process, opening up the film, putting it into the feeder, doing the whole thing. So I'd gone through that process. I was then gifted the little plastic cup with 18 films in it. So my very competitive and over excitable personality, I could not have opened them fast enough. And they were duplicate film. So I'm opening up 2 films, shoot them in, 2 films, shoot them in, 2 films, shoot them in. I glued them all together. I put them in so fast because I didn't understand how it worked that it came out in one big full FMX sheet that I then had to take back and say, okay, I feel like maybe this is not what we wanted.
Yeah, but they were all attached to each other, so it was a full mount. It was a true full mount series.
It was, but none of it was diagnostic. Not one thing.
Yeah. I mean, and it was in a mounting of sorts.
It was an amount. You could have said to the insurance company, I have in fact taken 18 films and I did in fact mount them. And I did attempt an interpretation.
Yeah.
So I had to walk in. And can you imagine how much she hated me?
Oh, I mean, and especially, you know, that you don't get to just walk to the patient and say, oh, we're just going to print these out again.
No, no.
Yeah.
We're going to have to retake all 18 again.
Yeah. And patients, did you know that was the second most dreaded thing in the dental office? You know, everyone talks about the thing that kind of sets them off or the thing that they like the least. First is the sound of the handpiece, but second was they hated biting on the films because the films just didn't sit well. They didn't fit well in the mouth. And, you know, they were so pointy when they were just those little number 2 films. And everyone
it's not that much better now. I mean, it's okay. It is better, but it's not great. I mean, you kind of teased me, well, with your personality many years ago, but sometimes with your words. And you said one time, not that long ago, that you thought we would be really close to focal point enough that we could just go to CBCT. And I really wish that were the case because I throw those sensors out tomorrow.
Yeah, we it's funny because on, you know, the new office that we built, I do have intraoral heads in all of the hygiene rooms, but we only have a Nomad for the doctor side because we rely on CBCT so much. And then, you know, intraoral scanning and NERI and, you know, there's just so many other diagnostic tools that we use now. And really we have moved away from taking a lot of intraoral x-rays, at least on the doctor side. It's still, you know, still a necessary evil on hygiene to some degree, but
everybody wins when we can get to that point. Yeah. Time, efficiency, diagnostic. I mean, like everybody wins.
I think we'll be there very, very soon. I do. I see our guest made it to the waiting room too, which I am very excited. Yes, we have Dr. Ryan Dunlop and Dr. Michael Ling, and we'll introduce them later. But first, I think, do you have any news tonight?
Of course, always.
Other than where on the earth is Chad
Duplantis?
Yeah.
No idea. He
Does
didn't
anyone
disclose
know?
his location.
He did not disclose his location. All right.
We'll figure it out.
Okay. All right.
I'll put the right people on it.
Anyone who wants to venture a guess at where in the world Chad Duplantis is, just let us know. And
Boy,
we'd
that
love,
could go south so
yeah,
fast.
we'd love to hear your thoughts.
Yeah.
Yeah.
Your honest thoughts, really.
All right, JB, why don't you do
Okay.
some news? And then we've got an incredible segment tonight because everybody talks about, you know, I would like to sell more big cases, and
Yeah.
they'll take some courses, they'll learn how to provide the treatment, but when it gets back to being in front of the patient, it's that's where the rubber meets the
Yep.
road, and so many people have a really hard time with getting the patients to commit. They're interested, but getting them to commit, getting them to be fully vested in their own treatment. And these guys we're talking to, they're gonna not just talk about the logistics of how to do it, but the logistics of how to get patients to say yes to. And that applies across implant dentistry and just larger restorative cases. So stick around. We're going to talk to them. And right now, here's JB with some news.
All right. Just a couple of fun stories that are floating out there that I think are really important for our audience to know. So, first off, I think it's really important to highlight that it's been well understood for a while that periodontal disease or gum disease, as your doctor may diagnose, has a really high inflammatory marker. So there's lots of other systemic diseases that you may express that are also attached to high inflammatory markers. Well, two recent journal articles that came out very close in proximity to one another keep coming back to periodontal disease. They keep coming back to the fact that if you express that high risk inflammatory genetic disease process of periodontitis and the bacterial pathogens that come along with that, you now have a double risk presentation of eczema as well as a double risk presentation of migraines. So, a journal that came out in the European Journal of Neurology found an 80% greater risk of experiencing migraines for patients that express the periodontitis gene and or the periodontitis bacterial pathogen. So those patients had a higher risk for experiencing migraines on a regular basis as tracked over a period of time. And then subsequently, an article came out just also in proximity of that in the Public Library of Science 1 that also highlighted that patients that had periodontitis had a higher expression of eczema as well. There's something connecting all of these disease processes together. We've got to get to the bottom of this to figure this out because I think there's a really amazing opportunity to help patients with a lot of these autoimmune diseases as well as inflammatory markers. If we can understand, is it genetic? Is it environmental? Is it bacterial pathogen? Is it a combination of all of those things? Can we come together with treatment modalities that may help these patients prevent early tooth loss, but also many of the other systemic complications that come with it? In addition, the FDA is now cracking down on those ingestible fluoride tablets. So many of you may not know, but for a long time, doctors and dentists have been prescribing ingestible or tablet form fluoride supplements for patients, pediatric patients in particular, who lived in areas that were only fed by well water sources that had no fluoride supplementation. And so doctors very frequently, probably 20, 30 years ago, would provide supplementation for fluoride in areas where they knew the patients were not getting any exposure to fluoride to help prevent early childhood caries. Well, that ship is probably sailing. And I think those ingestible fluorides are pretty quick to be terminated. The notice has been sent. Oddly enough, as a dentist, did not realize that this was a pretty unregulated market and that a lot of the products currently as ingestible fluorides that are being prescribed have not been heavily reviewed. So that is a bit of a concern and definitely needs to be addressed. I really didn't prescribe these in practice because it was always really difficult to track trickle down exposure. Kids that were going to public schools, kids that were drinking sodas and juices that were being purchased at the grocery store, if they were made with municipal water sources, also had fluoride in them. Their toothpaste and other products that they were using over the counter had fluoride. So there's all these now exposures to fluoride. So it really wasn't part of my practice. But go back 20, 30 years ago, definitely was a big part of pediatric dentistry and pediatrics in general, to supplement with fluoride. So I think we're going to start to see the devolution of the use of fluoride supplements as an oral medicament that can be prescribed. Where that goes with municipal water supplies as well, topical fluoride applications, et cetera, to be determined. But that's kind of the first step that we're seeing coming out of the new administration. And with that, that's the news.
Great stuff. So it's really interesting because I think we're going to feel a lot of pushback from this fluoride thing, because the people who first alerted me to this were actually outside of dentistry. So yeah. So I think that these, these little news bits are really getting to the public a lot faster than the dental profession has a chance to actually say, okay, what are the ramifications going to be? How do we react? And, we just don't have that same amount of opportunity to figure out what are we going to say to our patients, because, yes, we're talking about like supplemental fluoride tablets now, but this is just going to elevate and escalate their concern about all fluoride application under any circumstance. So
sure. I think that's the problem that we're and I talked about that with the Tylenol announcement and pregnancy. And then it kind of leaves practitioners going, okay, well, great. How do we manage them? Chair side. When they come in pain, now what do we do? So it's one thing to make these statements, but then when you provide practitioners with no practical application of where they go from here, and Tom Viola talked about that when I saw him a week ago doing his amazing opioid lecture, and he said, I know this as of 3 weeks ago. This is really current information about how we're using Tylenol, how we're using Tylenol with vaccines, how we're using Tylenol in pregnant women. He's like, it's kind of drinking from a fire hose, and he's a pharmacist. It should be, top of mind for him. And it's just kind of coming at rapid pace. So anyway, we're all in the same trench.
Stay tuned. We are. Just between X-rays. How about like the patient radiation bib, the lead apron? Now, it's crazy the amount of conflicting information that is out there right now, and it's so readily available, and the fact that you can go into ChatGPT, ask it anything now, a lot of that information isn't right. It's just flat wrong, and so we have such a long way to go with that. I just think stay tuned to Dentists in the Know, because we're gonna unravel all these controversies for you. Unbelievable.
Would you like to introduce our guest?
I think that's what we should do. And quite honestly, this will be my first time meeting them. But I'm really excited because these gentlemen actually work with a group called Full Arch Masters. I believe Chad met Dr. Ryan Dunlop at one of the lectures he was presenting. I'm pretty sure he met up with him there. And I love what these guys are doing, because they're really helping people understand not just how to do the work, but how to get patients to say yes to that work. And I have so many questions because one of the things that you hear about, full arch implant dentistry and a lot of the dentists that dive into that arena is that, hey, I jumped into this. I thought it was going to be so profitable, but you're really married to a lot of these patients. And, one, I'm not getting the case acceptance that I wanted to get in the first place. And that's step one, is just getting them to develop trust in you, and that's probably the biggest hurdle when you're talking about a 50, 60, $70,000 case. But the next thing is how to execute, and then how to set expectations. I think that's such a huge piece of it, because anytime you put something mechanical in the human body, it is, it's not going to be the same as what God gave you. And in some cases, it might be better than what happened to what God gave you, but there are always going to be complications. And what I'm hoping to hear from them a little bit is how do you manage some of that on the front end with what you say, and in that trust building process. So we have Dr. Ryan Dunlop, and he's from Fresno, California. And we also have Dr. Michael Ling, and they are part of the Full Arch Masters group. Guys, it is absolutely my pleasure to meet you both. I'm really excited to hear what you have to say. And welcome to Dentists in the Know.
Thanks you very much. Thank you very much.
Yeah, you're welcome. And fun fact, JB, before we get started, is Dr. Ling actually has as many kids as almost as many as you, me, and Chad put together. So we're 7 across the 3 of us, and Dr. Ling is 6, I believe.
I know.
Right?
I'm not gonna catch you. You guys win.
No. Do we? Do we?
Do you
Do
really?
we? I don't know.
Yeah, depends on what you're talking about.
Hey, I admire the effort though. So, guys, thank you so much. Yeah.
What happened is they finally figured out what was causing all these babies and ceased those activities.
Yeah. Well, good luck with that.
No, that didn't happen. No.
Yeah. And that's why he's got a needle full of Demerol in his arm right now, right?
Right. Well, I had twins,
anyway.
so I'm on a different spectrum. We have 3 kids, and my second 2 were twins, and everybody stops at twins. Once you have
twins are really, really difficult. Really difficult.
I can't imagine that, because we had our first son, who was really just a very, I think the term is strong-willed child. And it took us 5 years just to get the courage to have a second child. Like, literally.
That too.
Yeah. And the second one was so easy. If we'd have had him first, we'd have probably been, right back in Dr. Ling's situations.
Right.
22 kids later, right?
Right. By the way, I should say that I actually know where Chad is.
You do?
It's
the funny story. I don't know if you know, but he and I actually went to high school together.
No, I did not know that.
And prom night, he actually stole my girlfriend, and they ran off together, and I hadn't seen him since. So I've been trying to track him down for 20 plus years. I heard he was doing this webinar. I'm like, I'm going to get him. And so I know where he is. He's hiding.
Yes.
So you think he's still at prom night, like looking for the next?
He's on the run.
Well, we can help you find him. Because frankly, we'd like to see his ass kicked once. Like, it would just be really good for us.
Yeah.
It's good for morale.
It may be a long time ago for him, but it feels like yesterday to me.
Yeah. The wound is still very raw. Yeah.
And I can't put fluoride on it. It doesn't work.
No.
Yeah. And you're not allowed.
It. Might as well eat it while you can.
Yeah. You'll get arrested if you do that. Exactly.
So thanks for having us, guys. This is a really fun
thank
topic.
you so much for being here. I absolutely love what you're doing. I have a lot of questions myself, but why don't you each, if you don't mind, maybe just take a couple of moments and talk about your own personal journey, and then how you decided to come together and do this thing with Full Arch Masters.
Sure. I'll start, Ryan, if you don't mind.
Go for
I
it.
just wanted to go back and correct, or maybe comment on one thing you guys said as you brought us out in terms of, we're teaching how to get patients to say yes. And I think it's a fine difference between getting patients to say yes and guiding them to solutions that we know are going to make them happy. And the old school way of case acceptance is like, Wolf of Wall Street, always be closing, slick lines, overcoming objections, those types of things. And I mean, today's consumer, whether in dentistry or otherwise, is just too sophisticated for that. And they have really finely tuned BS and sales detectors. And that type of communication is not very effective these days. What we teach instead is what I call sort, not sell, where when we meet patients, we're not selling to people who don't need help, who don't want help, and who can't afford help. We have to sort those patients out and let them leave with dignity or help them find another solution. But once we find patients who need it, who want it, and can afford it, we sell like hell to those people. And those people, by selling to them, we're actually helping them improve their lives and get something that they want. So I think dentists get themselves in trouble, or salespeople get themselves in trouble, is when they try to sell things to people who don't want it, don't need it, or can't afford it. And so that's why I don't really like the phrase of getting patients to say yes. What we're really doing is sorting buyers from non-buyers and helping the buyers buy and helping the non-buyers find something that's a better fit for them.
Mm-hmm.
I like that. That's really cool. So tell us, give us maybe the Cliff's Notes version of your early career and how you got into providing like full arch care like this, and then perhaps how this full arch masters thing came together.
Sure. So I started, I'm a general dentist, work in Hamilton, Ontario. Grew up in a small town, and my dad was a dentist. So when I graduated, I started working with him. He retired shortly after I graduated. And at the time, I was really heavy into like Dentaltown, and Scott Luna was a big figure on there, and kind of became a disciple of his, and ended up growing our practice. We're kind of focused on like a single location mega practice that did everything. Grew it to 25 ops, 60 people. And then I sold that practice in 2019 and then pivoted and did some startups. And then when we did startups in 20 and 21, the focus was still breakaway. It was still, I took Scott's courses again, and I'm going to do a couple breakaway practices, mini DSO, mini empire, flip it and retire a billionaire. That was kind of the plan. Didn't quite work out that way with COVID is one of the main factors. And then kind of faced with reality that, okay, we got these startups, so how are we going to get patients? It's not quite as simple as just opening your door and people are going to come flock to you. And so started getting heavy into learning sales and marketing, and kind of going down that rabbit hole, and learn from people like Dan Kennedy and Perry Marshall. Those are probably two of the biggest influences in my career. And then kind of evolving from that into high value sales and marketing. And at the same time, kind of got interested in implants. Took Dr. Dunlop's course and a ton of other courses, and now that's all I do is implants, and especially full arch, and really finding a passion for the marriage between the sales and marketing of implants and also the clinical side. And actually, I would probably rather just sit and talk to patients all day and do consults, and then let somebody else do the hard part.
Yeah, work your strengths, man. I love it.
How about you, Dr. Dunlop? Tell us, how did you start building this program?
Yeah, so I have always been the type of person who enjoyed sharing what I consider to be valuable information with others. When I think back to my childhood and my adolescent years, when I would get something as a gift, or I'd learn something really interesting, the first thing I wanted to do was share it with my friends. I was a big baseball player, and when I would learn a new pitch, I would immediately teach all the other pitchers how to throw it. It's just kind of the core fundamental of my personality is I don't like to hoard information, and I don't like to hoard opportunity. So when I became a dentist, I'm a GP by training. As soon as I would learn how to do a new technique, I'd want the people around me to know how to do it too. So similar timing around 2018, 2019, my startup practice was really flourishing and blooming, and I was very busy clinically, but I wanted to share information. So I started allowing colleagues to come and shadow me and learn and see some of the surgical techniques that I had learned and kind of mentor them. And that just grew into the need, as COVID set in, for kind of a formal education program. And that's how I created Full Arch Masters, was just out of my desire to help the community that I was in, and spread the wealth and spread the knowledge. And so we started doing clinical classes. We started doing treatment coordinator training type classes, laboratory classes, live surgical courses, and it just blossomed from there. And that's how I met Michael along the way. He signed up to take a couple of my courses, and we formed a friendship. And now there's hundreds and hundreds and thousands of people that we've trained all over the country and all over the world. And so it's a really strong community, and the doctors and lab technicians and assistants and hygienists, anybody who's come through the courses is all connected through social media and through chat groups that I've created. And so I have a group called the Full Arch Masters Marketing Think Tank. And there's a couple hundred doctors in this group, and we share ideas and strategies and questions about marketing and case selection and presentation. And Michael's very active on that group, always giving really good advice to people. So he came to me a couple of months ago and he said, "Hey, I'm putting together a course that's designed to help dentists, to empower them in their own offices to increase case acceptance and build value for the complicated and expensive treatments that we provide. Would you be interested in collaborating on this course?" And of course I said, yes, absolutely. We already do a lot of this, but I know that you are really an expert in this particular field. And the last thing I want to do is tell my colleagues and my alumni of my programs to just dump money into marketing, just write that big fat check every month and hope for the best. That's not the core fundamental belief of my program. I'm all about empowering doctors to make a better path for themselves. So that's kind of the nidus of all of this, is he reached out to me and said, "I'd love to collaborate on this. I'd love to draw up some more attention and make this a more robust program." So that's what we're doing. We're going to have a 2-day course in December in Phoenix. The weather will be beautiful.
Mhm.
And hopefully people want to come in and learn from what I consider to be the top level communication and sales techniques in the industry, things that I use every single day. I'm a full arch dentist. I do nothing but full arch dentistry, whether it's tooth supported dentistry or implant supported dentistry. Michael pretty much does the same thing as me. And so we're operating at the top, 0.5% of dentistry already. And we want to share these communication skills that we've worked on over 10 plus years on how to motivate patients to better themselves. And that translates into increased revenue and increased profits for your business.
So what would you say, because this is something that I've heard spoken in the industry, is that full arch dentistry, full arch implant cases, all on X dentists, however you want to refer to them, it sounds like this great prestigious thing that everyone wants to do, but finding that profitability in it can sometimes be difficult because of high laboratory costs, or the inability to actually find the right patients, and then the inability to speak with them the right way to have them actually see the value in what you're doing. And then the third piece of it is, how long are you married to these patients? How do you set expectations? So I know this is a big subject, but how do you find success in the profitability side of this? I mean, what are the keys, in your opinion, to making this something that is profitable and enjoyable for a lot of dentists?
Well, from my experience, and I've trained hundreds and hundreds of doctors to do this, the singular concept that provides satisfaction and profitability is control over the process. Controlling the process from patient intake all the way through to case maintenance and hygiene is a direct causative factor for happiness and success. When you outsource control, when you are relying on the laboratory, when you are relying on the marketing company, when you are relying on the surgeon you sent the case to do, it strips away most of the profitability and most of the happiness associated with these procedures. And these are very happy procedures. I mean, yes, it's tough. It's surgery. It's invasive, but the satisfaction and the dopamine release that patients get, and as a result we get, is unmatched in dentistry. There's nothing else that a patient can do for themselves in a dental chair other than full arch dentistry that's going to have that impact in their life so quickly. But if you outsource control and you take away the kind of command over the process, that's when profitability goes down, and that's when satisfaction goes down. For me, it's controlling the process.
Michael, did that educational piece also translate for you as well? Is that kind of what was the
Yeah. I mean, obviously Ryan's seen hundreds, if not thousands, of people go through this process, so he's kind of a different perspective than mine. I would just add that it's this type of procedure is really hard to do well and profitably if you're doing 1 or 2 a year. I mean, you might as well just not do it. You're just not going to. I mean, you can't take 6 hours for the surgery, and it's going to take you that long when you start. So you got to get reps, you got to get a workflow, you got to get your staff accustomed to doing it. So if you're doing 1 or 2 a year, I'd probably just refer those out, to be honest. But if you're doing, 1 a month, I mean, if you can find 1 a month, then you can find 2 a month. If you can find 2 a month, you can find 4 a month. And then once you get the ball rolling, I remember the first time I did a crown prep and took, 3 hours in dental school. And then now we're all 10 plus years out, right? You'd probably prep a crown with your eyes closed. So it's all just repetition. And then, like Ryan said, the process, the technology, the workflow, and the education is a big part of that, because before I went to Ryan's advanced surgery class, I was seeing cases and patients were saying yes. And I had to say, well, I can't do it. I mean, I don't know how to do this case. Right. So for sure, you need to take, once you're going to get cases, to take the education so that you can handle the demand. Because the worst thing that happens is you work so hard to get a case, patient's ready to swipe their credit card, and you're like, oh crap, I have no idea how to do this.
Yeah. And that was my next question is, and I guess, I guess, Dr. Dunlop, what my big question here is there's so many pieces to this. So there's the surgical skill, there's the laboratory skill, there's the technological side, the design to, the chops in 3D printing, and there's so many pieces to this. How do you break that up, and how do you stage that for the newbie that comes to you and says, yeah, I want to be a full arch dentist, but I mean, that's a lot to put on yourself to teach somebody, all of those technological skills and surgical skills. And then on top of it,
facial analytics. I mean, it's a multidisciplinary for sure.
Well, you need to have a partner. You have to have a mentor partner. You have to have somebody that you can lean on when you're having trouble, and somebody who's in a position to break it down into steps for you. I just finished a class. We just had our flagship course this week. We had, 12 or 14 doctors with their teams. So like we had, 30 or 40 people here. And everybody's at different stages of their development. We had one doc who's done 600 arches. We've had another doc that's done 6. And we had one doc that hasn't done her first case yet. So it's my responsibility to kind of break it down into the fundamental science and then the implementation of it. And so you have to have a partner that understands the different stages of the development. So over the last 5+ years, we've broken it down into stages for people. And so we're there to help shepherd people through the process, whether they've been doing implant dentistry for 10+ years, but just need to get faster and better, or they're just getting started. And so we were talking even about office design. Somebody's building their first office. And so how do they build an office with full arch dentistry in mind. So from the very, very beginning all the way through to people who are, in the last 10 years of their career and just want to operate at the highest level. So the partnership is the key. And I never had that. Michael never had that until he found Full Arch Masters, I think. I certainly never had that coming out of dental school in 2006. I had to figure all of this stuff out on my own, and my hairline has paid the price. It's hard. It's risky. There's lawsuits. There's mental stress. There's financial stress, and people do fail. People fail in their attempts to scale their office and become a full arch dentist, and that's where we excel, is by helping everybody at their level.
Is there an opportunity in your curriculum as well for those doctors who maybe don't envision being the surgeon? I mean, look, when you say control, I think that's the thing that also adds the next layer of receding hair and gray hair, is that everything that we do, we lose control of at some point. And it could even be just an insurance claim. Like, it leaves your office and you've lost total control of what happens to it, right? And whether they pay for that crown or not is really not within your control to help a patient out. The same is true, nail on the head, about having now to manage a surgery team, the laboratory team, and you as the prosthodontic team all coming together, or you being that singular person. But is there curriculum also for the doctor who doesn't want to own it all, but they want to know how it works? They want to know how to talk to patients to educate them, because at the end of the day, they want to make sure they've given patients every option. Like, yes, can you do an overdenture? Can you do a traditional denture? Can you do a fixed hybrid, an MK1? Like, all the different options available to them. I might not be the doctor for you, but I'm your GP. I'm your quarterback. I want to get you the right care. I mean, Michael hit that on the head. I just want to get you the right care that you need. Maybe I'm your doctor, maybe I'm not, but we want to empathetically get you to the right place. What does that look like for that doctor?
Well, I offer a variety of courses, and the one we just finished is a full workflow spectrum course, but it's predominantly a prosthetic course. Mm-hmm. I do the surgeries, and then we watch the patients go through the process. So I've seen it all. I've had people come to my courses who have never placed a dental implant in their life, but they want to restore these cases. And I have people who are surgeons who have never seen a tooth, and all they do is drill titanium and bone, and they want to understand the full process. This particular course that we're putting on in Arizona in December is just for better sales techniques and better communication techniques for all dentists. Anybody who wants to increase their revenue and increase their job satisfaction, increase their case acceptance rate, are invited to attend. Now, there's going to be a lot of full arch implant dentists there, because this is the hottest topic in dentistry and everybody wants to be on this train. But the same communication techniques that I use to motivate somebody to do a $50,000 or $60,000 double arch implant case are the same communication techniques that I use to motivate somebody to do a 24-unit veneer case. Mm-hmm. It's the same motivation techniques that I use for them to do an orthodontic case followed by single implants. There's no difference in the communication style and the value proposition building that we are going to teach at this course. So any dentist who is at a point in their career where they want to scale up, where they want to increase revenue, where they want to have more control over the sales process, because nobody in this room had sales training in dental school. Did you? I didn't. And no dentist in America had sales training when they were in dental school. So we had to all learn how to communicate and connect and build value with patients on our own. And so this is an opportunity for any dentist who wants to scale up their practice and increase their revenue by controlling the sales process in-house. This course is designed for you.
So Dr. Ling, one of the things that you talk about is kind of performing your consultations based on emotion and trust. What would you say? Obviously, you can't give it all away here, otherwise there's nothing to do out in Phoenix, right? But tell us a little bit about that trust building process and exactly what you mean by being emotionally based in your approach.
Sure. I mean, in terms of the emotional based approach, the key idea is that none of our patients are buying implants. Even the ones who come in and say, I'm interested in implants. Do you guys do implants? They're not buying implants no more than they're buying a root canal. I mean, nobody wants their nerve pulled out of their tooth and then bleach poured down the roots. I mean, that's not what they want. What they want is to get a good night's sleep and the pain to go away, right? And so that's really the emotional side of what we're selling. Is we're not selling implants. We're selling freedom from a lifetime of pain and stress and frustration, and embarrassment is a huge one. And we're selling transformation. We're selling a better life and a brighter future. So the emotional side of what we sell is focusing our consults on the patient's emotional condition more than their clinical condition. And when we're doing implants or full mouth rehabs, I mean, any experienced dentist can look at a pan or a cone beam, peek at the patient's mouth, and in 2 seconds know, is this a full arch case or is this a restorative case in general? So, I mean, diagnosing the clinical condition is very, very easy. Diagnosing the emotional condition is much more difficult, and a step that I think most dentists miss just because we're not conditioned to think like that. I mean, we're engineers, we're scientists. We see a missing tooth, we want to fill the missing tooth, fill the missing space. Right? We see a loose denture, we want to secure the denture. And it's really easy for us to fall into that, professor / teacher / engineer role. And the fact is that that's not what motivates patients because they're not buying titanium and zirconia. They're buying a better life. And if you can be that one dentist who understands them and connects with them on a deeper level than giving them a dentistry 101 lecture on the biocompatibility of grade 5 titanium, then they're going to trust you and they're going to choose you to be the one who's uniquely suited to solve their problem. And at that point, price shopping becomes irrelevant, right? People will pay more to work with somebody they trust versus if you sound and look and feel like every other dentist, then what's the difference? I'm just going to shop around and find a better price.
Love it.
I couldn't agree more. And I think you're completely correct in that we don't teach dentists enough about empathy and how to sort of like peel back the onion just a little bit more to figure out where that patient is at that time, emotionally and mentally, and how we can, take a part of that journey with them. And also, I have found being creating an environment in which the patient is okay to say no today because they're going to say, yeah, that's the right thing for me in the future. Like accepting them where they are at that moment and saying, we're here for you. We'd love to support you through whatever journey you decide. And then they go home and they stew on it, and they often will come back and they're like, you're the doc for me. This was absolutely the procedure I want. I just needed time to process and mentally kind of get through the barriers and sort of figure out where my next steps are going to be.
Mm-hmm.
And part of that is just patience on our side too, to say, absolutely. Like GP is a long game.
I mean, I could rant for 3 hours on just what you just said there, because there's just so much to unpack. And so part of it is absolutely, we're guiding the patients in the direction they're already going. And we certainly don't want, especially, I mean, Ryan knows this more than anybody. The last thing you want is to convince somebody to do full arch.
The worst.
And then something goes wrong. And it's like, well, it was fine until you touched it. And you convinced me to do this. And you promised everything would be great. The last thing you want is to convince somebody. So we don't convince anybody. We just guide them in the direction they're going. Now, having said that, the typical full arch patient hates the dentist. Like they have a lifetime of dental trauma.
Right.
Yet they're sitting in your chair. Okay. So how many people go to a restaurant, book a reservation, look at the menu, and then get up and don't order anything? Right. So this person hates the dentist, yet jumps through a dozen hoops to sit in your chair. Something is going on with that patient that made them want to do that. So they're leaning towards getting help. Okay. So, yes, we're guiding them in the direction they're going, but just them sitting in your chair is an indication that they want your help. So it's really your job to guide them with ethical persuasion and influence towards solutions that we know are going to make them happy. Again, assuming that, I mean, they qualify, they need it, they want it, and they can afford it. But we guide them intentionally to solutions that we know, and this is a little bit of a difference. Well, not a little, but this is a huge difference between the way that we do it versus the way the conventional wisdom is. So the conventional wisdom is you look at the patient, do an exam, give them all the treatment options, the pros and cons, and then just let them decide, right? And that's kind of the way that we were taught. Just be an impartial observer. I'm just reading the weather. Here's what you can do. You let me know what you want to do. And I don't agree with that method because it, first of all, leads to confusion. Patients leave more confused than when they started, and there's no guidance. I mean, patients chose you for a reason. There's somebody that is more convenient and cheaper than you, but they chose you. And usually it's because they saw you somewhere, saw an ad, saw something you wrote, saw your face somewhere, and they like you. They came to you for your expertise. So I think it's a shame.
Actually, it's because I'm listed on Delta Dental. I'm just kidding.
So, what we do instead is we intentionally guide patients to solutions that we know, based on what we know about this patient, are going to make them the happiest, the longest, with the lowest chance of long-term regret. And sometimes that's full arch. Sometimes it's saving your teeth. Sometimes it's going into a denture. So we're not guiding them to the most expensive solution. We're not guiding them to the solution that's best for us. We're guiding them to the solution that's best for them. But man, once we know they want it, they need it, and they can afford it, we sell like hell to these people and guide them to that solution because we know it's going to make them happy.
Well, I think you really hit on something too. You know, having a one size fits all approach, it really just never works in dentistry. And we know that a lot of people who end up in a situation where they need full arch dentistry, they need something like this. It's because one, they either weren't motivated, they were afraid, they were, caries prone, they had periodontal pathogens, whatever the reason. And I think it's really our role to determine not just what condition they came in with, but how it got that way in the first place, so that you can kind of help guide them to the solution that doesn't allow them to have the same negative outcome at the end. Because, if you take somebody who is still not motivated from a hygiene perspective, or perhaps harbors a lot of the periodontal pathogens that can also, be responsible for peri-implantitis, and we haven't really addressed all those things, then I think we haven't done our due diligence as dentists. And I think that goes to a lot of what you're saying about trust, is that part of what we have to do is to say, listen, I understand you're here and this is non-judgmental. Let's figure out how you got here, and let's figure out what we need to do to give you the most successful outcome. And maybe if that's someone that's like not motivated for hygiene, maybe that is an overdenture with a couple of locators that they got 2 spots that they have to keep clean. I'm just curious what your perspective is on that.
I think it's a fine line, right? So on one side, imagine you were going to see your medical doctor, and you needed a heart procedure. Would your medical doctor say to you, no, I'm not going to help you with your heart. I need you to prove to me first that you're going to earn it. I'm going to check your diet. I'm going to make you do this and this and this. You got to stop smoking. And then maybe I will give you the honor of me helping you. Right. So that's one side of it. The other side of it is you're absolutely right that we don't want to, we can't hurt people. And we don't want to leave them in worse situations than when they started. So we absolutely make clear to our patients that we're giving you a second chance. We're hitting the reset button. We're not curing. We're curing your disease. We're not curing the cause of your disease. And that's your responsibility. We can set you up so that you have the greatest chance of success. But you also have to make a commitment on your end to change your habits. Otherwise, you're going to end up in the same situation. So it's a fine line. I mean, we absolutely have that conversation with patients, but what can we do? I mean, at some point, the patient has to take responsibility. I don't think we can hold their treatment hostage until they quote unquote earn it. We have to have the honest conversation and make sure and forget about legal consent. This is, human to human conversation that, we're hitting the reset button for you and giving you a second chance. What you do with that second chance is up to you.
I had a patient not that long ago. We did full over full fixed hybrid, and 50 plus year smoker, done. Because she got a second chance. Like sometimes it's just that mental reset of this is something I bought and I've invested in, and now I'm a new person. And you know what I mean? Jeff, like that constant.
Right. And imagine if you had said to that patient, okay, you proved to me you stopped smoking for a year and then come back and I'll help you.
Yeah. But I wouldn't have guessed you would have stopped, frankly. I mean, that really was like a beautiful ending to a story. It was not what I had written on the wall. I really thought, we'd be
people
cleaning
will
it off.
surprise you. I mean, people surprise me all the time. That dentistry, we're trained to be scientists, engineers, and clinical minded people, but people's smiles and their eyes, like those are like the two gateways that we interact with. Like, and when you fix somebody's smile and you see the change that it really gives them when you're doing these, big reconstructions, it is not uncommon for people to change their entire lives. This is an inflection point.
That's crazy.
It's an inflection point for people, and they carry the childhood trauma and they carry the young adult trauma all the way into middle age and into their senior years until they get their smile fixed. Yeah. And I have 80-year-olds who are they change their lives. I mean, they've spent 80 years struggling and suffering and being insecure and not fulfilling their life's potential because of their smile and how ashamed they are. And they're 80 years old, and now they're re-engaging with family and traveling and starting businesses and going back to school. And it's like, it's never too late for people to turn over that leaf and have an inflection in their life. And smile reconstruction is, I think, one of the biggest things that people can do for themselves. And like Mike said, they don't come to us for titanium. They don't come for us for zirconia. That's completely irrelevant. I've had entire consultations with patients and never mentioned once what a dental implant treatment plan. Like, not once. Like, come to me, we have a human conversation. I understand what their wants and their desires and their fears are. And we talk about those things for 20 to 30 minutes. And then at the end, I say, okay, well, we are going to do this. We are going to do this together. And then they look at me and say, I'm sorry, what are we going to do? And I say, oh, I completely forgot.
It's a toupee. We're doing a toupee.
We need to talk about the actual treatment plan, and then I'll transition to a little bit more technical stuff. But the patient's sold and ready to go and motivated, and we've never talked about what we're actually going to do. How was I able to achieve that? And it's because of these communication techniques, and it's organized. It's not just a free flowing. We're not just going to tell you guys, oh, just be nice and communicate with your patients. There's an actual formula that we're going to teach you on how to harness the power of the want. People do not buy full arch dentistry. They do not buy big case dentistry because of need. There's a small subsection of people that buy it because of need, because that's just who they are. They're very technical. 98+% of people are buying full arch dentistry because they want it. And if you're not good and you don't have a structured strategy for getting to the want, you will never be able to close these cases at a high rate.
Love it. So guys, I mean, I can't believe we're already through an hour here, but is there anything else you would like to, I put fullarchmasters.com. I assume that's where they can get all the information for the course that you're doing in Phoenix.
Actually, you can go there. Fullarchmasters.com has information on it. We also have a dedicated website just for this course. It's called domorearches.com. So you could change that as well to be domorearches.com. They can go to that website, or the Full Arch Masters website. There's information on both locations, but domorearches.com has a full breakdown of Dr. Ling's protocol, and has a lot of information about exactly what we are going to be teaching at this course. And we invite dentists to come, any dentist that wants to scale their practice and do things and have more control over the sales process is welcome to come. We also invite treatment coordinators and office managers to come to the course with their dentist, or they can come on their own. So if there's a dentist that wants to send his sales team to this course and he or she is not able to attend, we have an option for that. Obviously, we want the dentist to come themselves. We want them to learn these techniques, because my treatment coordinators tell me that I hand patients to them on a silver platter every single day. And I have associates who work for me, and I've had associates in the past, and I have business partners all over the country. And that is not a unanimous decision. Doctors are not always handing their treatment coordinators patients on a silver platter for them to finish up. So we want dentists to come. We want them to bring their sales teams with them, because this is going to be an interactive course. Dr. Ling talked about reps. There's going to be a lot of reps at this course. We're going to rehearse, and we are going to practice, and we are going to put you guys in a position to really absorb and implement all of these strategies.
Well, that's great, guys. And I would actually love to talk about the treatment coordinator, that whole concept, because I think that we could probably spend a weekend on the different takes on what a treatment coordinator truly is or should be. And I'd love to have you both back and hear your perspectives on that sometime. But
sure. We both have excellent treatment coordinators that work for us that would probably be willing to join us.
Yeah. And I think that that's a great topic, because there's a lot of dentists who really try to take on too much of this themselves. And really, we have our skills, we have the things that we should be saying. And I love what you said about serving it up on a silver platter. Just, here it is, go ahead and take care of it and make it fit their needs at this point. So love it. Thanks for being Chad's friend, because God knows he needs some.
Yeah, anytime.
He has none on the top row. So.
Yeah. But yes, guys, we really we thank you for taking time out of your busy schedules to join us. If there's any more information you want to share, please let us know. We'll be happy to put a post up about it on Dentist in the Know tomorrow. But we thank you for your time. We thank you for your expertise, and we thank you for sharing with the rest of the dental community, because I really do think that's one thing that sets our profession apart, is we really are a bunch of people that want to help each other for the most part. That old saying that, if you looked at a dental firing squad, it would be a big circle. I don't really believe that. I think most of us really do want to lift the profession. So,
well, I went to a dental school where we were mixed with medical school. So the first 2 years of my dental school was mixed with the medical school, and then we broke up and did our separate things. And I can tell you without a doubt that the more helpful and more collaborative people were on the dental school side. And the medical school, it was cutthroat and competitive, and they did not want to help each other. So, the medical students stayed on one side and all the dental students stayed on the other side. And after class, all the dental students would go home and have parties and hang out and get to know each other. And the medical students would all scurry away like rodents in the night.
Well, the fact that you said 20 or 30-minute discussion without even mentioning titanium, MDs can't even like that. It doesn't even compute.
Right.
Doesn't even compute.
Yeah, I love it. Okay, guys. Well, another great
for one day.
Yeah, another great show, JB. And thank you both again for joining us. To all of you out there, keep listening, keep watching. We'll keep bringing you great information like this. And with that, another Hump Day Happy Hour out. So hope Yeah. Hope you all have a great night.
Take
Thank
care.
you. Have a great
Good
evening.
night.
Good night. Thank you.
Good night, everyone.
And that wraps up another podcast for Dentists in the Know. On behalf of Dr. Jennifer Bell, Dr. Chad Duplantis, and myself, remember that we've got a great profession, so let's make it a great day, Dinks.